Welcome to our Part 2 of Pulmonary Medicine Review. ARDS is defined by a PaO2-FiO2 ratio. That's 300 mmHg with PEEP, 5 mmHg H2O. This ratio helps determine the severity of hypoxemia in ARDS. Management consists of low tidal volume ventilation of 6 ml/kg, plateau pressure less than or equal to 30 cm H2O, PEEP titration, 5 to 15 cm H2O. Adjust. PEEP to improve oxygenation. If PaO2 is low, the first step is to increase PEEP rather than FiO2. This is to avoid oxygen toxicity and promote alveolar recruitment. ARDS management includes permissive hypercapnia with higher CO2 levels and respiratory rate, 35 breaths/min, and ensuring pH, Dichtalto, 7.25 for safety. Prone positioning and avoiding fluid overload is recommended. In a healthy, mechanically ventilated patient, normal EtCO2 is 35 to 45 mmHg. In cardiac arrest, EtCO2 greater or equal to 10 to 20 mmHg indicates adequate chest compressions. EtCO2 persistently less than 10 mmHg after 20 minutes suggests a poor chance of ROSC. A sudden rise in EtCO2, often 35 to 40 mmHg, is an early indicator of ROSC. Spontaneous breathing trial, SBT. Assessment for extubation begins with a spontaneous breathing trial for 2 hours. We assess the following criteria, including RSBI, which is respiratory rate divided by tidal volume and should be less than 105, along with good mental status. Few secretions, strong cough, and no upper airway lesions. If all criteria are met, the patient is ready to be extubated. If any criteria are not met, place the patient on assist control mode, continue daily SBTs. Consider tracheostomy if weaning is not successful after 10 to 14 days. Adjust ventilation based on ABG results. If hyperoxia with PO2 greater than 90 mmHg, then we decrease FiO2. If hypoxia with PO2 less than 60 mmHg, then increase PEEP. If pH less than 7.25 with high PaCO2, then increase respiratory rate. If pH more than 7.45 with low PaCO2, then decrease tidal volume. The ETT is usually inserted to a depth of 21 to 23 centimeters. In endobronchial intubation, asymmetric chest rise, whereas esophageal with abdomen rise instead. An incorrectly placed endotracheal tube in right lung can be seen in the picture. Auto-PEEP refers to positive pressure that remains in the alveoli at the end of exhalation due to incomplete lung emptying. This can lead to dynamic hyperinflation and increased work of breathing. Expiratory flow does not return to baseline before the next breath begins. This results in breath stacking, visible on the flow time waveform. Management includes decreasing respiratory rate or decreasing tidal volume. Using bronchodilators and applying external PEEP cautiously helps as well. Aspirin-exacerbated respiratory disease is characterized by Samter's triad, which includes asthma, chronic rhinosinusitis with nasal polyposis, and sensitivity to aspirin or NSAIDs. Ingestion can lead to acute asthma exacerbation and other symptoms like flushing of the face. Avoiding NSAIDs and considering leukotriene receptor antagonists like montelukast or aspirin desensitization are key strategies for managing this condition effectively. A reduced DLCO in isolation suggests vascular pathology like thromboembolism or pulmonary hypertension or early interstitial disease. It's important to consider non-pulmonary causes like anemia in the diagnostic process. NPPV in cardiogenic pulmonary edema patients enhances oxygenation via improvements in respiratory and cardiac indices. The intermittent use of non-invasive positive pressure ventilation in patients with chronic respiratory failure from chest wall disease like kyphosis, scoliosis, or obesity has been shown to improve dyspnea, sleep disturbances, and mortality. It also may partially reverse cor pulmonale. If Hilar led with systemic symptoms like fatigue and tiredness, especially in African patient, concern for sarcoidosis. Preferred initial test is endobronchial ultrasound with nodal aspiration, which will show non-caseating granuloma. Erythema nodosum can be present in sarcoidosis as well. We don't biopsy erythema nodosum. Massive hemoptysis caused by bronchiectasis, aspergilloma, necrotizing pneumonia, and rarely bronchogenic cancer requires immediate airway protection and resuscitation. Rigid bronchoscopy is the procedure of choice for effective management. Aspergillosis can present with different presentations. First is allergic bronchopulmonary aspergillosis, ABPA, which usually happens in patients with asthma or cystic fibrosis. It presents with allergies/asthma, with wheezing with high eosinophils, and IgE along with bronchiectasis with recurrent infiltrates. It can have mucus plugging with hemoptysis as well. Diagnosis by positive skin test, elevated total IgE, and positive Aspergillus-specific IgE or IgG. Chronic pulmonary aspergillosis occurs in individuals with pre-existing lung disease, including tuberculosis, COPD, or sarcoidosis. It presents with weight loss, chronic cough, hemoptysis, and progressive fatigue and breathlessness. It's diagnosed with CT chest showing cavity with a fungal ball and positive Aspergillus IgG. Invasive aspergillosis happens in severely immunocompromised patients, those with neutropenia, solid organ transplant, or stem cell transplant. Clinical symptoms include fever, cough, hemoptysis, pleuritic chest pain, dyspnea, and signs of sepsis in severe cases. Diagnosis is with CT chest with nodules and ground glass opacities, halo sign. Positive serum galactomannan is present. Tissue biopsy revealing fungal hyphae. Aspergilloma, fungus ball, occurs in patients with old lung cavities, typically from TB. Patients are often asymptomatic, may present with hemoptysis, which can be severe. Diagnosis with CT chest showing a mobile mass within a pre-existing cavity. Treatment is observation if asymptomatic and surgical resection or embolization if there's massive hemoptysis. Candida growth in respiratory secretions rarely indicates invasive candidiasis and should not be treated with antifungal therapy unless necessary. Unilateral diaphragmatic paralysis results from phrenic nerve injury, often after cardiac surgery. Symptoms include dyspnea at rest or exertion, supine hypoxemia, worsened oxygenation when lying down. Diagnostic findings include spirometry with decreased FVC when supine, chest X-ray with elevated hemidiaphragm. Fluoroscopy has positive sniff test, which is paradoxical upward movement of diaphragm, which confirms diagnosis. Methemoglobinemia reduces oxygen carrying capacity, leading to functional anemia. It can be precipitated by drugs like dapsone, benzocaine, lidocaine, or nitrates. We suspect this in patients with cyanosis, chocolate-colored blood, and gap between pulse oximetry and ABG. Treatment is with methylene blue. Lung cancer screening is crucial for early detection. It is done with low-density CT scans in patient 50 to 80 years old with greater than 20-pack year smoking history. In a patient with spiculate mass and pleural effusion, if initial effusion is negative for cancer, we repeat thoracentesis, and if malignancy is still suspected, we do thoracoscopy. Thank you for joining us in this exploration of pulmonary medicine. We hope you found the information valuable and insightful.